Good evening, everyone. I am Shifa Sheikh from DocPlexis. As we all know, DocPlexis is India's most trusted and leading digital platform dedicated exclusively for doctors, focused on enabling continuous medical education and professional networking. I'm delighted to welcome you all for very interesting and another important session on very important topic, that is recent trend on management of macular hole. As we might be aware, recent trend in management of macular hole focuses on advance in surgical technique and improve visual outcome. Plana vitrectomy remains a gold standard, with newer approaches such as internal limiting membrane, that is ILM, peeling, and inverted ILM flap technique, significantly increasing closure rates, especially in large or refractory holes. The use of shorter acting gas tamponades and faster post-operative recovery protocols, including reduced need of prolonged face down position, have improved patient comfort. Additionally, adjuvants to platelets-rich plasma and growth factors are being explored to enhance healing, while early diagnosis with optical coherence tomography and has enabling timely intervention and better prognosis. So for this very interesting webinar, it's my absolute pleasure and to welcome our esteemed speaker for today's session, Dr. S. Natarajan. So once again, we welcome Dr. Natarajan on our DocPlexis platform. Dr. Natarajan is renowned ophthalmologist with over 35 years of experience, with particular expertise in vitreoretinal surgery. He performed the first completely sutureless buckling and has performed over 60,000 vitreous and retinal surgery. Dr. Natarajan has held several honorable positions, including as the president of Internal Ocular Trauma Society and the chairman of International Committee of All Indian Ophthalmology Society. So, without further delay, I would like to hand over the sessions to Dr. Natarajan. Over to you, sir.
Good evening. Thank DocPlexis for the session. I'll share my screen. So you can see my screen?
No, sir, not yet. Yes.
No?
Yes.
Okay. So my talk is on recent trends in management of a macular hole. And a full thickness macular hole is a defect of the foveal retina involving its full thickness from the internal limiting membrane to the outer segment of the photoreceptor layer. It was first described by Knapp in 1869 in a patient who sustained blunt trauma to the eye, and subsequent case reports and series in those early days revealed macular hole to be related to trauma. However, case series as far as back as 1970s reported that more than 80% of macular holes are idiopathic, and that only less than 10% have associated history of trauma to the eye. And you can see this is a fundus picture of a patient with a macular hole. And before 90s, there was even the vitrectomy was available, but nobody applied it. Only after Dr. Wendell, who applied vitrectomy and sealed the macular hole. So worldwide prevalence 3.3 per thousand, more than 55 years of age. And India 1.7 per thousand, more than 67 years of age. And female, so for some reason, have more than the male, and fellow eye in about, that means bilateral, happens in about 12%. And the etiology is generally idiopathic when we don't know the cause, vitreous syneresis, posterior vitreous separation. When the post retina separates vitreous from the retina, it can produce chronic cystoid macular edema, trauma, contusion injury, accidental laser injury, lightning, progressive high myopia, where the stretching of the retina happens like this, foveal schisis, and lamellar hole. That means some part of the superficial layers, there's a hole happening, preceding rhegmatogenous retinal detachment. Successfully repaired rhegmatogenous retinal detachment, less than 1%. Pathogenesis, the Lister proposed vitreous as pathogenesis in 1924, and Gass in 1988 found the vitreomacular traction theory, focal shrinkage of foveal vitreous cortex, producing intraretinal foveolar cyst formation, and then the unroofing of the cyst happens, becomes a macular hole. Torname et al. Proposed the hydration theory, post-hyalo traction of fovea, there's a tear in inner fovea, seepage of fluid vitreous into spongy layers of macula, cavity in the inner retina, enlargement of the hole, then spread to outer retina, and swollen retina remains elevated and retracted. So earlier, as I said, before 1990, there was no surgery possible, or a same vitreous surgery was not applied. Only when Dr. Robert Wendell presented it, his series, then everybody started using it from 91. So the standard treatment, which is standard care, is a pars plana vitrectomy with internal limiting peeling of the membrane and gas tamponade. And high success is observed in small macular holes. And there are various techniques. The one is a inverted ILM flap technique, which is following macular scars technique. But there are various techniques. There are temporal flap. The mechanism, there is a scaffold for glial proliferation, better outcomes in large macular hole, more than 500 microns. And the modified ILM techniques improve closure in refractive macular hole, especially useful in large holes and myopic macular hole. And the meta-analysis supports improved anatomical success. So there are a lot of surgery or proponents where some use full gas, some use reduced gas with shorter phase duration, and still the results are anatomically comparable. And some don't use even air, and some use only air, and improves patient comfort as needed positioning and approach emerging. So no face down trend is in some eyes in selected small holes and where you have a better compliance. And there's a new thing which has been designed and which I have designed along with a Akruti and made a new one called, it's a macular. It's called the dehydrated amniotic membrane, specifically designed for retinal use. And this is an advanced biomaterial solution. And Natarajan macular is a biologically active graft derived from the innermost layer of human placenta. Its inherent properties make it an unparalleled tool for managing challenging retinal condition, offering a novel approach to tissue repair and regeneration, and is particularly indicated for challenging macular hole cases, including refractory macular hole, high myopia associated with macular holes, where conventional internal limiting techniques often fail. So this is mainly for large holes, more than 400 micron, with chronic macular holes, refractive cases failing initial surgery, high myopia associated with macular hole. The other uses, at present, the one what is available as an Natarajan macular is a pre-cut into 100, 500, 1,000, 1,500, and 2,000 micron size. But in giant tear, we have to use a big uncut one so that we can cover the entire RPE, high myopic retinal detachment, and other maculopathies. The key innovation in the mechanical sealing mechanism, how MacuSeal works is a anti-inflammatory and anti-fibrotic, minimizes postoperative scarring and inflammation, promotes epithelial healing, accelerates the recovery and regeneration of damaged tissue, and its immune privilege, reduce immunogenic reaction in adjacent tissues, ensuring better integration. And regenerative scaffold supports optimal cellular adhesion, proliferation, and migration for tissue repair. MacuSeal offers features a proprietary biomaterial formulation designed to integrate seamlessly with the retinal tissue, supporting the body's natural healing process. The biocompatible design engineered to integrate with retinal tissue without adverse reaction, ensuring long-term stability. Mechanical support provides a physical scaffold that prevents fluid ingress and promotes the reapproximation of retinal edges, and optimal degradation designed to degrade gradually as natural healing occurs, supporting tissue regeneration. So the healing integration process, the tissue integration, cell proliferation, tissue modeling, and functional recovery. So the advanced delivery precision, MacuSeal's precision application system ensures accurate placement over macular hole and retinal breaks, minimizing trauma to surrounding tissue. As I said, it's available in sizes from 500 to 2,000 microns in diameter and 50 to 100 microns in thickness, and specially designed Pele-Singh MacuSeal forceps is used to handle these membranes.
Introducing the Pele-Singh MacuSeal forceps, developed by Akriti Ophthalmic, a precision-engineered surgical instrument designed exclusively for handling MacuSeal, the dehydrated membrane used in retinal surgery. Upon opening the sterile pack, moisten the tip of the forceps with balanced salt solution, BSS, to activate optimal grip. Then, gently grasp the membrane laterally, ensuring maximum surface coverage within the heptic span of the forceps. This technique allows for secure, non-crushing handling, preserving the membrane's integrity during delicate intraocular placement. Crafted for control, designed for safety, Pele's Sing Macuseal forceps empower retinal surgeons with confidence and precision. Accredi ophthalmic, advancing vision, ethically and expertly.
So that's about the forceps, which is designed by Dr. David Pele's from Argentina. And one is the inlay technique, and the other is the overlay. And I generally prefer overlay technique. The inlay is where the membrane is precisely trimmed to size and placed directly within the macular hole, acting as a direct plug. The method is often preferred for smaller, well-defined hole. In this approach, the membrane is positioned to cover the entire defect and surrounding retinal tissue, and this is typically used for large holes or those with irregular margins, providing broader coverage. And here you see a graphic video of how a macular hole is happening. And then where after the macular hole, the macrocyl can be placed under air or even under PUCL. So this is how the forceps. So I have also made a new design of how to release the macrocyl from the forceps onto the surface of retina atraumatically. So the clinical benefits and result, more than 85% anatomical closure rate. Studies show impressive success in refractive macular hole, significantly higher than the traditional methods. Improved outcome, demonstrate efficacy in chronic or persistent macular hole case, offering new hope. Reduced reinterventions, minimizes the need for repeat surgeries, decreasing patient burden and health costs, and reduce face down positioning, eliminates or minimizes the need for prolonged face down posturing. So this is a 57-year-old male, came with complaints of decrease of vision in right eye. He had a history of trauma to the right eye after being struck by someone's elbow while traveling on a train. And diagnosed he had a macular hole, fundus superior lattice, superior temporal quadrant, horseshoe tear with a rhegmatogenous retinal detachment. So you can see this is the OCT, which shows the macular hole with a vision of preoperative vision of counting finger half meter. And this is a fundus photo. And then we have planned, because the patient had a peripheral detachment, we planned peritomy, where 360-degree conjunctival peritomy was done. And then the isolation of rectus muscle, and all the 4 recti muscles were tagged. So I'm making a scleral flap. Now here first I'm making the suture after localizing the retinal break in the periphery so that we can place the buckle. And then I'm also placing the 240 band below the muscle and then passing this behind the sutures. And this is being done 360 degree. And the other quadrants where the buckle is not there, you dissect the flap and then pass the clear the encircling band all around, and then tie the band using the Vatsky sleeve. So here you see the Vatsky sleeve being used, and you can tighten depending on what tightening you want, moderate tightening, so that you can produce a buckle effect, and also using the scleral buckle to keep in position. Here you see a vitrectomy is in progress after putting the buckle in position. 3-port pars clamata is being done. Peripheral vitreous excision is being done. And you can see a retinal detachment in the superior half and with the macular hole. So we are using a steroid to cut the uncut vitreous. We stain the vitreous and remove the vitreous gel when it is uncut. And now you are using the perfluorocarbon liquid, and then doing the laser in the periphery where there is already a lattice degeneration and around horseshoe tear, and now tightening the buckle so that you can have a little moderate buckle, and also tightening the buckle suture and leaving it as a loose knot to check the height of the buckle. And you can see the retina is attached fully with the laser around the lattice degeneration and the horseshoe tear, and make sure that there's no fluid. And now removing the PFCL, and there was now taking the membrane from the packet, and then applying a drop of and using the other force, and then using through the 20 gauge. And now I'm using with a candle illumination, illuminating the vitreous cavity, and with my left hand, I'm pushing fluid to wash the membrane away from the forceps, and then now the membrane is on the surface of retina. I'm doing a fluid air exchange, and you can see the membrane is moving little. So I'm now placing the membrane over the surface of the macular hole to close the macular hole, and then make the patient lie down in supine position for about 2 hours, and then later you can change to the prone position so that the flap doesn't move. That is the macular Natarajan macular seal does not move. And then close the conjunctiva using the glove, and also give subconjunctival injection, a subconjunctival antibiotic injection, and also steroid injection. And you can see 6/8 post-operative, the vision improved to 6/18 with the graft in position, and then the total healing of the macular hole. And you can see the 360-degree encerclage with the buccal effect superior temporally. And this is a case 2. A 23-year-old male came with complaints of decrease of vision since 15 days. He had history trauma by tennis ball while playing cricket, and diagnosed with full thickness macular hole. And you can see this is a fundus picture, and the full thickness macular hole is the pre-operation 6/60. And then 25 gauge 3-port pars-plana vitrectomy is being done. Anterior and posterior vitrectomy is done. Completing the posterior vitrectomy, and the PVD or induce the PVD using the suction of the vitrectomy machine, and make sure that most of the vitreous is removed.
चाहिए
नहीं,
इसमें दूं
नहीं, पानी. So now I'm using the brilliant blue to stain the internal limiting membrane, and then I remove it under the air. I do the staining, and then I use the retinal brush to do a endodenite. So right now I'm using the retinal brush to remove the PFCL and also the fluid from within the eye. So now using the flexi loop to make a nick in the internal limiting membrane. I'm using the forceps where the nick is made in the internal limiting membrane after staining. And this is done under the fluid. After fluid air exchange, I do the ILM staining. And then under the fluid, I do the ILM peeling. So you take the different flaps so that you can do the ILM peeling and make sure there is a hinge left near the macular hole so that you can use the ILM as a plug for the macular hole. You can see the ILM peeled all around, and the ILM is still attached to the edge of the macular hole. So now using the ILM flap, it's over the macular hole. So it closes the macular hole. And I'm doing a fluid air exchange, make sure that the ILM is not moving so that it is closing the macular hole. And make sure that the eye is dry and total fluid air exchange is done. And this is the post-op vision where you can see 636 improvement post-surgery and the macular hole is closed. And then the take-home message, ILM flap is a key innovation. And then personalized care using the various size of Natarajan MacuSeal, which is available. So, and then the prone position nowadays, if you have done the ILM peeling and the gas, not strict positioning is required. So, thank you very much.
Yes, sir. Thank you so much for your valuable explanation.
Right.
Great explanation, sir. So during your explanation, sir, we got a few questions from our audience. You almost covered everything. I just wanted to take 2 to 3 questions.
Yes.
So yeah. So the first question is, sir, as per your experience, how do you choose between gas tamponade option and has your preference changed with newer evidence?
Gas tamponade and then what are the other one?
How do you choose between gas tamponade option and has your preference changed with newer evidence?
No, even though there are presentations, people are using air. And then recently I saw somebody has done vitrectomy and no air, no tamponade. So I still use non-expansional gas mixture and put the patient on prone position. But I tell them that you don't have to be strict, but some hours a day is enough for a week. So I still prefer the gas. It's my personal choice.
And the next question, sir, how critical is intraoperative OCT in your current workflow? Has it changed intraoperative decision making?
No, I don't have intraoperative OCT, and I've seen people using it. And the whole thing is you can watch what you're doing if you have the intraoperative OCT. And only problem is it adds cost to the equipment, and that's one of the reasons I didn't take it. But still, in practice, I think that even though people have, I think they're not using routinely. The reason is even without the intraoperative OCT, you will be able to see that the macular hole getting closed, and while doing the fluid air exchange. So that's why, as of now, I think the use of intraoperative OCT is still minimal, maybe for subretinal injection and also for the gene therapy in the future. Maybe it will be required, definitely, which you can't see with the regular naked eye.
Okay. Thank you, sir. The next question what I would like to ask. Also, what has been your experience with intubated ILM flap technique compared to conventional ILM peeling in larger molecular holes?
So the main thing is that I still earlier I started doing the conventional ILM peeling, but now I do like this. You saw the last patient, like a multiple nicks I make in the ILM, and then make the flaps coming in multiple layer like a lotus flower over the macular hole, which I feel is good, so that the traction of the ILM over the macular hole is released, as well as it uses as a plug instead of totally removing the ILM and then doing a fluid exchange.
That's great, sir. Thank you so much for answering all the questions. So, on behalf of entire Doplexis team, we really thanks Dr. Natarajan for sharing your valuable expertise and deep clinical experience on such an important topic on recent trends on management of macular hole. So, your session has truly helped bridge the gap between technology and everyday clinical practice. And we also want to thank all our participants for joining us today and your active engagement throughout the session. And we hope you found this discussion very informative and clinically relevant. So on behalf of Doplexis, we look forward to welcoming you all for our upcoming educational program. Till then, have a great day ahead. Thank you so much, sir, for your valuable explanation and your contribution.
Thank you very much.